very much. And thank you so much for inviting me. We've been talking about this trip for years, it seems like, and it's really a very special trip already for a number of reasons. It's wonderful to be here. And as we all sort of in our small circle know, Maria and I are best friends from residency. We were interns together. And I was the maid of honor at her wedding. And we travel around, but we never get to be in the same sessions together. So this is the first time that this has happened. So thank you for that. So you're going to hear from me 4 times today. The first talk here is about colon cancer screening and surveillance. And the last 3 lectures are going to be about genetics and really a primer in GI cancer genetics. Now, in discussions over the last couple of days, it's clear that in Colombia you're not doing systematic colon cancer screening in any way yet. And what I hope to tell you, or show you what we've learned in the US and hope that you can learn from our mistakes, because I think we've made lots of them. We're going to review the available standard screening tools, and I'm going to talk about also the new approaches that are being considered or have been considered for screening, including stool-based DNA analysis and virtual colonoscopy, and then spend probably half of the lecture on some of the pitfalls and the challenges of colon cancer screening application. So we're going to start with 3 questions. Just think about these. We're going to come back to them at the end of the lecture and think about your answer. So which of the following is not a recommended option for colon cancer screening for an average risk individual? Annual fecal occult blood testing, flexible sigmoidoscopy every 5 years, virtual colonoscopy every 5 years, stool DNA testing every 5 years, or colonoscopy every 10 years. Second, which of the following patients should have a repeat colonoscopy in 3 years? A 60-year-old man who's had a right hemicolectomy for cecal cancer, a 45-year-old woman with 4 6-millimeter adenomas found on a colonoscopy done for rectal bleeding, a 70-year-old man with 3 hyperplastic polyps in the rectum, a 50-year-old woman status post piecemeal polypectomy of a 2-centimeter sessile adenoma in the transverse colon, or a patient with Lynch syndrome with a 3-millimeter adenoma. And the third question is really the same choices, but which of those patients should have a repeat colonoscopy in 3 to 6 months? So just think about your answer. So first of all, let's talk about risk of colon cancer screening. Now, these are US numbers. The general population risk in the United States is 5%. So 1 in 20 individuals will get colon cancer. And I understand in Colombia it's about maybe a third that the gastric cancer rates are higher here than colon cancer. But as you are seeing, as has been seen in most Western countries, is that as your gastric cancer rate decreases, the colon cancer risk increases. And you're seeing the same thing here, I think. So it's going to become more and more of a problem in the future. If you have a personal history of colon cancer neoplasia, either an adenoma or a cancer, your risk of a second event is higher. So 15 to 20% of individuals will get a repeat event in the future. In the, so let me do this way. In the high-risk syndromes, in the last 3 lectures, we're going to talk about some of these increased risks in the hamartomatous polyposis syndromes, Lynch syndrome, and FAP, and as you see, the risks are dramatically elevated compared to the general population. So we're going to focus now on average risk, and this is really the individual who's really age over 50 and has no risk factors and has no symptoms. And in the US, we've really made a decision that something needs to be done for this patient population. You have lots of choices: annual occult blood testing, sigmoidoscopy, annual occult blood testing plus sigmoidoscopy. Double contrast barium enema was part of the decision for many years, or colonoscopy every 10 years. Now let's review some of the data that pertains to these choices. So this goes back now almost 15 years when we learned about the effectiveness of occult blood testing. Large studies are available, so 15,000 patients that looked at annual screening as well as biennial screening. And what we learned is this number here, is that you can definitely affect colon cancer mortality by offering systematic occult blood testing by about 20%. And you can do it either annually or every other year. Now, what's new in this area is what type of occult blood test that you use. We've used guaiac tests for many years, and the problem with that is that they're non-specific. So they cross-react with hemoglobin. You need to do 3 tests for screening if you're going to do it. You need to restrict the diet. It's not specific it's supposed to be specific for lower GI bleeding, but it's not usually. And it really gives you a qualitative answer, but not a quantitative answer. The new tests that are out there are the immunochemical tests. And these tests are designed to be specific to the hemoglobin antibody. So you only need 1 test if you're going to do this. There's no dietary restriction, and they are much more specific for lower GI bleeding than the standard FOBT. So the programmatic changes that are happening in the United States, where we are using occult blood testing for the population, really the move has been to use FIT testing rather than the standard FOBT for this approach. Now, what about flexible sigmoidoscopy? This has gone out of favor in the US, but I think, as you're going to see, there's lots of interesting new data about this. So the advantages are that it's a simple test. There's no sedation. The preparation is simple, and it can be done in the office. The disadvantages are that if you find a polyp, you have to move on to a colonoscopy to remove the polyp. Patients actually don't like it because they don't get sedation, and of course you get incomplete visualization of the entire colon. And this raised a lot of questions about 12 years ago when we were using flexible sigmoidoscopy as our standard tool for all patients in the US. And there were several studies that showed that distal adenomas actually didn't predict proximal adenomas, and that we were going to miss a significant number of proximal cancers if we just relied on flexible sigmoidoscopy. Now, we have recent data that actually shows definitively that sigmoidoscopy does work. It's effective at decreasing mortality by about 20% in the general population. So we didn't have these data, and actually just showed it does show that it works. But again, the question is the protection from right-sided mortality. Now, how about colonoscopy? This has been adopted in the US. I think we're the only country that has done this. It's part of the recommendations of multiple national guidelines. But really, we have no data on the efficacy of whether this works or not. And I think in the US, I'm not sure if we'll ever go back to other modalities, but in other countries, whether we can use this as a primary tool is really not sure. And as you'll see in the next sort of later on, there are lots of data that show that there are actually problems with using some colonoscopy, that it's not actually as good as we had hoped. So this is a Spanish study that is being conducted right now that's going to compare FIT testing with colonoscopy screening. And last year, we had some preliminary data from the study that showed that, that if you look at patients' acceptability of this approach, people actually were much more likely to do FIT testing than to do colonoscopy. The risk of colon cancer was actually, or the pickup of colon cancer was the same in both groups. The advanced adenoma detection rate was higher in colonoscopy than with FIT testing, but the complication rate was also higher. So I think as you think about doing this as a population, again, I don't think we have the answer about whether FIT testing is the right one or colonoscopy. But it's going to take us 10 years to find out the results of this study. Now, what about newer approaches to screening? So the ones that we have looked at in the United States include virtual colonoscopy and stool DNA testing. To start with virtual colonoscopy, this is just a fancy CT scan of the colon. And this was the original paper that generated lots of attention in the New England Journal of Medicine. This is a virtual CT image of a colon polyp compared to the endoscopic image. And as you can see, the pictures look beautiful. What they showed in the study was that the sensitivity rate of virtual CT scans was actually identical, and if not better, for large polyps than it was for colonoscopy. So lots of excitement until we had some larger studies that were done that looked at a large scale at virtual colonoscopy. And what it showed is that the sensitivity really increases for large polyps, but it's quite low for smaller polyps. And we as gastroenterologists know that these small polyps are markers of risk. And the specificity is not great. So the big problem is that there is lots of cross-reactivity with stool, and the positive predictive value, if you have an abnormal CT scan, is only about 25%. So a lot of these people are going to go on to colonoscopy and actually not have polyps found. So right now there's still lots of questions that are sort of unanswered in this technology. There needs to be standardization. Radiologists actually don't like doing this. It takes a lot of time to actually read these images. We have not been able to figure out how to get reimbursed for this study, at least for average risk screening. And what's clear is if you're going to do CT scans for colonoscopy screening, patients are going to need to have a colonoscopy if they have a polyp found. And patients don't want to get prepped twice. And so we'll have to coordinate between endoscopy sites as well as the radiology sites to coordinate this all in one day if we're going to do this effectively. Now, stool DNA testing was another approach that about 7-8 years ago generated a lot of excitement. And the idea is basically that your colon sheds DNA all the time. And this can be either due to bacterial DNA or through tumor DNA. And the idea is that if you capture a stool sample, you can extract the DNA from the stool and pick out the mutated DNA that represents the DNA from this progression to adenomas and cancers. Lots of interest in the initial studies until this large study that was a multi-center trial that looked at 5,000 patients, and really the bottom line is that the sensitivity for cancers was higher than FOBT, but for advanced adenomas, it was really the same. So the available tests for stool DNA testing did not compare to or did not improve upon FOBT testing, and at that time, the cost for this test was about $1,000 compared to pennies for the occult blood testing. So it really wasn't a good approach that was feasible for our general screening. Now, there are lots of ongoing studies that have improved generation tests that are going to look at improvement of adenomas screening rates, and I think in the next few years we may see this, but it hasn't really hit prime time even in the United States as a general screening tool. So how about moderate risk? I think this, most of us know, it's sort of standard bread and butter for most of our screening. So if you have small rectal hyperplastic polyps, the recommendation is just to follow the average risk recommendations. If you have 1 or 2 tubular adenomas, sorry, I'm not getting this, follow-up colonoscopy is recommended in 5 years. The special groups to consider, which are in those questions at the beginning of the talk, are if you have multiple adenomas or a high-risk adenoma. So 3 or more adenomas, a large polyp that is greater than 1 centimeter, villus histology, or high-grade dysplasia are markers in the future of higher risk adenomas. So these people should not be brought back in 5 years. They need to come back in 3 years. And the second large group, important group to remember, is a large sessile adenoma. So these are the polyps that we take out in piecemeal fashion, often in the right colon. And what you have to do is bring these patients back within 3 to 6 months, ensure that you have the polyp out, and I'll show you some data that really shows you why we need to do this. And then if you have a normal exam after an adenoma, bring that patient back in 5 years. How about after a cancer diagnosis? Make sure that the patient has had a clearing colonoscopy before their cancer operation or shortly thereafter. Colonoscopy is recommended 1 year after the resection, and then after that, every 3 to 5 years, and really we've gone to an every 5-year surveillance program for the vast majority of these patients. If you have somebody with a rectal cancer, with an advanced rectal cancer, who has gotten radiation treatment, you have to actually look at that distal rectal segment every 6 months for the first couple of years because of a very high rate of local recurrences. Now, this is not something that we think about for the colon, but for rectal cancer is a special consideration. And family history. So we're going to talk a lot about this later on in the day, but if you have an affected second-degree relative only, the recommendations are to do the same as average risk. If you have one affected first-degree relative, start surveillance 10 years earlier before the earliest cancer diagnosis. And then the special group we're going to talk about is more than one affected relative. You need to really individualize the age of onset of surveillance and frequency. So moving on to, these are sort of the recommendations. These are the approaches that we should be following. What are the challenges as we look to offer this and implement it in our populations? So the first one is compliance. I'm not going to talk about this, but we have a lot of data that suggests that patients, don't want colonoscopies. They don't like them, and we obviously, that's why we're looking for better tests down the horizon that will give them another option. Constellation of choices. So patients are very confused by all these choices. They want the doctors to tell them what to do. They have difficulty with deciding amongst all these different tests. So I think it's better if we're sort of directive and offer our own opinions as well as helping the patient make their decision. But the real issues that we've focused on in the last few years is quality. So we all do colonoscopies routinely. We all think we're great at it. And what the recent data show is that we're actually probably not as great as we think we are. So first of all, risk assessment. You need to get the family history if you're going to make the right recommendation. And this is a patient from our clinic that came in whose mother was diagnosed with a uterine cancer at age 50. Her aunt was diagnosed with ovarian cancer at age 49. She had a grandmother and uncle with kidney cancer and a cousin with colon cancer at a young age. And she went to her gastroenterologist looking for a colonoscopy and was told that there wasn't a first-degree relative with colon cancer, and she didn't need a colonoscopy till she was 50. She was about 43 at that time. And a year later, she developed her cancer. And really, this patient fulfills criteria for Lynch syndrome, and you need to sort of make these connections if you're going to make the right diagnosis and offer the right treatment. And family history assessment, I think, is a big issue in our clinical practice, that how to get it right and to make these diagnoses of these high-risk syndromes is important. Now, how about interval neoplasia? This is the big problem I think that we're learning about, is that lots of people who are getting colonoscopies for screening are still getting colon cancer, and there are lots of reasons for this. The first is that we're missing lesions, and we can miss them for a number of reasons. One is that the exams that we do are incomplete, so we think we're at the cecum, but we're actually not. So one of the things to tell the fellows is that you have to document when you get to the cecum, and you have to be sure that you get there. Too quick look, we're going to talk about this withdrawal time issue. Poor prep quality. If you have a poor prep, you haven't done a screening colonoscopy, and you have to bring that patient back. That's one of the big issues. Incomplete removal. So these big polyps that we think we've taken out, that we haven't taken out completely, they grow back and they become cancerous while we're waiting for the next colonoscopy. They're clearly fast-growing lesions. So they're polyps that don't take 10 years to develop into cancer. And to figure out which ones these are is a big challenge. And then there are these non-polypoid lesions, which are flat polyps that I think we have very big difficulty in detecting with our standard colonoscopy that are causing problems as well. So what's the risk? This is the first paper that showed us that, that there's a risk of interval cancers. These were large trials that were conducted for chemoprevention, and they looked at patients within these trials who got interval cancer. And the incidence rate was actually much higher than expected. And if you looked at these cases of individuals who got these incident cancers, so a pattern emerged. So these tended to be right-sided cancers, proximal to the hepatic flexure. They were early stage, but there were also several late stage cancers that had been missed. 5 of these patients had a large adenoma that was removed piecemeal in the years before, and the risk of an interval cancer was higher if you had multiple polyps in your initial colonoscopy than afterwards. And then we have 2 large studies in the last couple of years that have really driven this point home. So the first one looked at, they compared people who had colonoscopy versus those who didn't. And if you look at left-sided colon cancer mortality, there was, as we'd expect, a 67% reduction in colon cancer mortality from colonoscopy. If you looked at right-sided colon cancer, there was no reduction in right-sided colon cancer mortality. Now, these were people who'd had colonoscopy. And people didn't know what to make of the study. And shortly thereafter, there was another one, a cross-sectional population-based study, thousands of patients. And look at this. There was an overall reduction in mortality from colonoscopy of a half. But it was all from left-sided cancers, and there was actually no reduction in right-sided colon cancer mortality at all. So this brings back to question that whole flexible sigmoidoscopy debate. The whole reason we're doing colonoscopy is because we think it does better than flexible sigmoidoscopy, but the data are showing us that we actually may not. So this we've talked about. Cecal intubation, adenoma detection rate. You need to make sure you're spending enough time in the colon, and you need to describe the bowel preparation. So I'm going to skip this. I think all of you know this. You need to aim for an adenoma detection rate of about 25%. And flat polyps. So I think these are probably the biggest factor in our missing right-sided polyps. They're flat lesions. They're difficult to see. You need to spend a lot of time in the right colon if you're going to be sure that we're not missing these lesions. And then in the U.S., this is, a big problem. Colon cancer litigation is increasing, and the medical legal risk is shifting. And it's all about failure to follow screening guidelines, the quality of examinations, and failure to systematically document, track, and follow up on testing. So let's go back to these questions. Which of the following is not a recommended option? And the wrong answer is the stool DNA testing every 5 years. It's not a first-line recommendation for screening, and it would have to be done more frequently than every 5 years. Which one of these patients should have a repeat colonoscopy in 3 years? So it's the multiple adenomas. So more than 3 adenomas, you need to bring them back in 3 years. And in the 3 to 6 months, we've also talked about the sessile adenoma in the right colon that is removed piecemeal, needs to be brought back to make sure that you've taken the polyp out completely. Thank you very much.